Welcome everybody to this panel, AI for the next generation of precision oncology. So by way of introduction, my name is Lei Xing. I'm a professor of radiation oncology and also by courtesy electrical engineering. And we have 4 panelists today. The first talk will be given by Professor Joe Liao, who is a urology professor, professor urology from Stanford Hospital. And the second talk will be given by Ruijiang Li, who is associate professor of radiation oncology. And then the last one, but not least one, will be the Professor Mohsen Beati. So he is a professor of operational research. So without further ado, we're gonna start with our first talk by Professor Joe Liao. Joe, are you ready to share your screen?
Yes.
All right, great.
Can everybody see my screen?
Yes.
Well, thank you, Professor Singh, for that very kind introduction. And over the next 20 minutes or so, I'm going to share with you about some of the work that we're doing to develop AI. It's a little bit different, but in a more of the clinical setting, particularly in the clinic and in the operating room. As Dr. Singh mentioned, I'm a professor of urology at Stanford, so I'm a clinician, but I also have a strong research interest and run a translational research lab collaborating with a variety of folks, both at Stanford and beyond. So let me go to my next slide. So this is the outline. So I'm going to give you a bit about bladder cancer in terms of the background and current management. This is probably something that you haven't heard a whole lot about, but hopefully by the end of this talk, I can convince you that this is not only an important problem, but a worthwhile problem to study. And I'm going to highlight a couple of projects that we've done over the past couple of years. One is to apply computer vision to improve clinical documentation endoscopy, which is the endoscopic procedure we use both for diagnosis and also removal of suspecting bladder lesions. And the second project is a deep learning project in which we apply that to improve tumor detection with the hope that we can this in the future towards better resection. And just some comments at the very end on future outlooks. In terms of the background, during this conference, you probably have heard a lot about some emerging clinical applications of AI. And a lot of this resides in radiology and pathology, and that makes a lot of sense. A lot of data to go through, and AI is extremely powerful to help us sort of sift through that volume data. Another area is electronic health records. How do you apply techniques such as natural language processing to better extract the information? What I'm going to talk about today is actually potential applications in surgery and specific urology, since that's the area of my clinical practice. And in some areas where AI is starting to be seen in urology include the diagnosis of urinary stone disease, which falls under the realm of urology. How do you actually better assess skills at the time of surgery? And the part that I'm going to talk about today is how can we use AI to improve detection and the surgical resection of cancer. Bladder cancer is very common. It's actually the 6th most common cancer in the US. There are over 80,000 new cases per year and about 17,000 deaths each year related to bladder cancer. The risk factors, this is a cancer that occurs in elderly patients, more men than women. Smoking is by far the largest risk factor, and 50 or higher % of the patients with bladder cancer could be attributable to a history of smoking, and also other types of environmental and workplace exposure. So what about precision oncology and bladder cancer? So kind of this on the right-hand side, you see the presentation in terms of the cancer stage for bladder cancer. So when we speak of bladder cancer, which the most common form is called urothelial carcinoma that arises from the lining of the bladder. So this could be a small tumor that you can see inside the bladder, but it can also invade into the tissue that's deeper than the lining. So on the depth of the invasion, we can sort of assess the overall stage, ranging from something that's limited to the epithelial lining called the epithelium to something that invades deeper. And so we give it a stage of TA, T1, T2, and etc. One of the very important layers is the bladder is a muscular structure. So if the cancer were to invade into the muscle, we call that muscle invasive cancer. And the treatment for patients with non-muscle invasive bladder cancer and muscle invasive bladder cancer is vastly different. And as you can see here, the 5-year survival for early stage is on the order of greater than 90% for TA and T1 disease. However, once it gets into the muscle, the 5-year survival rapidly declines. If you have very locally invasive disease, the 5-year survival is actually on the order of 10%. So early detection, early diagnosis is absolutely critical. But the current strategies to sort of help us determine patients with high risk, low risk are really imprecise. And this is where precision oncology comes in. And that, you can think of that as in precision diagnostics. And bladder is particularly well suited in that we use urine as a source of biomarkers, which could be collected non-invasively. We do imaging as well in the form of endoscopy, but also there are the other types of more traditional settings where you can get the biomarkers, including serum and tissue. Precision surgery, which is where I'm going to focus most of my talk on, has to do with endoscopic surgery. So that's the treatment of choice for patients with non-muscle invasive disease, and more traditional open and more recently robotic surgery for patients with muscle invasive. I'm not going to talk about open and robotic surgery today. And lastly, precision therapy ties in with precision diagnosis and surgery in that is the way to sort of couple some of these targeted forms of diagnosis and imaging in the form of therapy. Just a few more slides on background because I really want to set the stage. The most presenting signs and symptoms for patients with bladder cancer is blood in the urine or hematuria. That usually then lead to a workup in an office setting in which we put a small flexible endoscope while the patient is awake into the patient's bladder to examine the inner lining of the bladder. If there is an obvious tumor or a suspicious lesion or a sort of indeterminate lesion that's found in the bladder, then it's recommended to go to the operating room in which we can either biopsy the area or actually fully resect that tumor to obtain pathological diagnosis. And again, depending on the stage, the patients can either be managed endoscopically or through a larger surgery by, in this case, removal of the entire bladder in patients with muscle invasive disease. This is what a bladder cancer or sort of bladder lesions can look like inside of the bladder. And it comes in the full spectrum, ranging from something what we call a papillary tumor, as you can see here, to something that's kind of more appearing, kind of this red patches we see in the bladder. And then in this example, you have some combination of both. Again, this is a heterogeneous disease with heterogeneous presentations. And while urologists are quite good at interpreting these lesions, we also know that this could be highly subjective in nature, especially for lesions that are indeterminate. And so many times that if there's an indeterminate lesion, that actually requires a separate biopsy procedure, which carries amount of morbidity in some settings. So in terms of some of the unmet needs and sort of the goals that we have is to really develop a higher quality cystoscopy and this particular surgery called transurethral resection of bladder tumor. That's the name of the endoscopic surgery. So the quality of resection we know is absolutely critical, and that kind of makes sense. Technique does matter. and especially regarding the margins, both the sort of the peripheral margins, but also the depth of the margin. You need to make sure that you actually remove it all, particularly muscle. I'll just play a short video of what this TURBT procedure looks like. So this is a video where we're inserting a larger instrument called a resectoscope into the bladder, in which we're using electrothermal energy to remove that papillary tumor. So what you can see here is that it's very technical. We go in and we resect the tumor, and we have to sort of visually assess, do we get it all? Do we go deep enough? Do we actually biopsy all the suspicious lesions within the bladder? Not surprisingly, there are shortcomings with this procedure. Again, some tumors are very obvious, but some simply are not. We sometimes can miss tumors as frequently. These cancers could be multifocal. They can happen in really anywhere within the bladder. The tumor may not be completely resected, both in terms of the number and also its depth. The flat lesions that I spoke a little bit about, they're actually very hard to differentiate between what is the background and the inflammation, especially in patients who have had recurrent disease. There's been technology that's been developed to sort of overcome or to make visualization a little bit easier. And this is a technology called blue light, in which we can actually put a fluorescent agent inside of the bladder to help us delineate the border. And this has been shown to improve tumor detection. However, it's a cumbersome to administer. It is quite expensive. It's actually not very widely available. Bladder cancer being both how common it is and how frequently that it recur. One of the goals is in our field is to really, how can we reduce the treatment-related morbidity, since these patients can actually be on lifelong surveillance, and also all the financial costs that's incurred for these frequent visits. Endoscopy that I mentioned, for surveillance purposes, so patients are recommended to undergo as every 3 months in order to do the surveillance. So my research group has a lot of interest in developing better ways to do image-guided transurethral resection. While the fluorescence technology that I talked about, there's also other microscopic and molecular imaging. Again, those are all terrific technologies, but what I'm going to focus on today is really to see how we can optimize standard white light endoscopy. And this is where I think artificial intelligence has really a role in which that we can actually extract maximum information for this extremely common procedure that we do. So again, the goal here is that can artificial intelligence help us to improve bladder cancer detection, and both in the forms of better classifying the lesion when presented with the image, to do object detection, as well as segmentation. One of the first projects that we worked on, this is done a few years ago, is how can we better document cystoscopy? Again, as I mentioned, patients could be undergoing the procedure in a clinic setting up to every 3 months, and that generates really a lot of data. And what the standard now is that we have these clinical notes that we put into the computer, into the electronic medical record, saying that Mr. So-and-so has a lesion on the right side of the bladder. It's approximately this size. And this is what it looked like 3 months ago. After resected, this is what it looks like now. Sometimes we may take a snapshot of that image and insert it into the patient's medical record, although that's by no means a standard practice. On the other hand, as I mentioned, we generate enormous amount of video data that's really frequently just discarded. I would say 99% of the time that information is just really not safe. So one of the questions we asked early on is, can we actually combine the richness of the information in cystoscopy video and be able to deliver in a way that's actually easier to access and interpret? And this is where we've taken a software-based approach to actually develop a 3D bladder reconstruction using standard white light videos. And this is the work done by a colleague, Audrey Bowden, who moved to Vanderbilt a couple of years ago. And what we did, along with a very talented graduate student, Kristen Laurie, was that we took a series of patients with a full-length white light cystoscopy video. There was minimal modification in the technique in these videos were acquired, and we made sure that the entire bladder is scanned with multiple overlapping regions. And the videos are broken down to individual images that are overlapping. Then using a technique called structure from motion, then we were able to generate a 3D point cloud from these 2D images, and then followed by generation of a mesh, and then to sort of juxtapose in a mosaic fashion of these different patches together to reconstruct that bladder. This is an example of a reconstructed video. And so again, this is taking a full-length cystoscopy video from a patient who's had a prior tumor resection, and then putting the 2D images together, and to then be able to reconstruct this bladder. And it's completely driven, and then one can actually sort of scan in and out inside of the bladder, exploring. And I think the potential applications would be as a way to maintain medical records. You can actually use this for preoperative surgical planning, as that we are in a teaching, and also a capacity to compare the similar area of the bladder over time. Again, these patients are monitored very, very intensively. And it's also a way that we can actually do optical annotation, in that some of the imaging tools that we have and instruments that we use are actually quite small as it relates to the bladder. And we can actually generate sort of a 3D coordinates of where that lesion is in that particular time point, and be able to come back to it at a later time point. Moving on to our other project, and we dubbed this SysNet. This is actually done in close collaboration with Professor Singh, who is the panel leader for this session. And this is a study that we undertake to better recognize detection of bladder tumors, and we focus on the most common type of tumor called papillary urothelial carcinoma. And we took a training set of close to 100 patients and who had biopsy confirmed papillary urothelial carcinoma. So having that imaging pathology correlation, sort of establishing this kind of a gold standard initial training set, was very, very important to us. And then we included with many different frames derived from patients without bladder cancer. And the lesions were manually annotated, and this was followed by a test set using a CNN algorithm. And after we developed the test set with a pretty reasonable sensitivity and specificity, this was then applied to a independent validation set, consists of another 57 patients, half of them with cancer, half of them with normal. And we were able to generate a per frame basis of a sensitivity of close to 90% and specificity of 99%. It's very exciting preliminary data. And then this is just a video showing a couple of the examples. And so this is done, as you can see, object detection here, and that the tumor itself can be tracked in real video. And as you can imagine, this will be very helpful if to sort of highlight the area of interest for a clinician at the time of either cystoscopy or TURBT. Things that we have done since then is to really kind of expand into different directions, including applying this in real time, developing better ways to annotate lesions, particularly the more challenging flat lesions. We're in the process of developing a comprehensive image set, next generation of the algorithm, and with the hope to integrate other both clinical parameters and also biomarkers to do multimodal data integration. This is, I'll sort of speed up, but this is an example of now we're actually in an operating room at the same time, where we actually have the laptop with a SysNet preload onto it, and then we can actually visualize the kind of in parallel right next to this is the operating room monitor, and then we can actually resect in real time. You can see how the algorithm is tracking the tumor in real time.
So you have a 2 minute.
Okay, thank you. And again, we are taking a very systematic approach to take a much larger cohort of data now to do annotation, going from image to video, having a panel of urologists along with a board certified pathologist to review our pathology content. We then will annotate to define, based on expert opinion, the border of the lesion, and then to maintain quality control. And just the sort of the final work that I'll highlight is that we're now moving from static images for training purposes to using video clips. And this is a work done by an instructor in the lab, Okias Eminaga, which what Okias was able to do is to take a single snapshot of a lesion of interest, generate a QR code, and then he's able to then actually go back in full-length video and extract a short video segment that's around the snapshot. And this, again, is another strategy for better writing. This is using a computer vision annotation technique in which now we're actually annotating longer length videos instead of just single images. So just to end with this slide here, that our goal is to develop precision diagnostics that can guide precision therapy for bladder cancer. We are interested in early detection, risk assessment, and treatment monitoring through integration of biomarkers, imaging, informatics, and AI. And our hope in the future, if a patient comes to the Stanford or elsewhere, is that we can actually come up with a more dynamic medical record that we can track patients' timeline with the relevant images that are taken both in the clinic and the OR setting, follow the lesion over time, and superimpose that with biomarkers that we're also developing in our lab. I'm going to stop right there and just want to thank the folks in the lab, and particularly to Dr. Singh as our key collaborator, and I'll be happy to take any questions after this. Thank you.
Yeah, it's a great talk, Joe. Congratulations for all the nice work. So now the floor is open for questions. You can type in your question from either Slido or from the Zoom chat, if you can. I'll just start with a quick question. It is a very fascinating piece of work. But at the beginning, you mentioned that the bladder tumor has, the smoking has a lot of influence on the bladder tumor. I mean, that's for a physicist or scientist, and that's a little bit counterintuitive. I can understand, for lung tumor, yes, but for bladder, other than any biological basis for that?
Yeah, that's a very good question. So bladder cancer, actually after lung cancer, has the highest somatic mutations. And I think that's actually due to the large surface area of exposure. In the lung, obviously, you can have the smoke that interfaces with the airway. And the bladder is actually the contact time. A lot of the toxins and that gets excreted into the urine, there's a contact within the bladder, and it could be mutagenic. And so that is the thought that, there's just a large surface area of direct contact with these mutagens that are related to smoking. And in fact, one of the most commonly used mouse model we use is to basically have the mouse eat the main carcinogenic compound found in smoking. And very characteristically, within 3 months, every will develop bladder cancer. So it's a matter of exposure of the epithelial lining.
Well, that's great. Yeah. Well, thank you. Let me see whether there's any other question from Slido, or if not, we'll move on. Just a second. Yeah. Well, it looks like people need to get used to the Slido. So we'll move on. So let's see. The next speaker is myself. So I will share the screen. Let me see. All right. Can you all see my screen? Yes. Can you let's see, just a second. Can you see my screen? Yes?
Yes.
Okay. Okay, great. All right. Let's get started. All right. I'm gonna talk about AI and medical imaging relate and for personalized cancer treatment. So I mean, we are heading to a new age, quote unquote, data-driven oncology. It's actually I think this new trend is started with deep learning and roughly about 2015. And yeah, I just want to remind everybody actually I think data-driven is as important as the fundamental physics to our life. You all heard about this code, right? But with data, and this is what I'm claiming. So if you gave me sufficient data and a computational resource, I can solve all the decision making in your clinic or in your life. So I guess the challenge really come from multiple aspects, and most fundamentally, as I feel that first of all, we have a lot of diseases, even for cancer, right? Different type of cancer, and Joe just gave a very nice overview on bladder tumor, but that's only one of many different type of cancers. And overall, in the human, we're talking about over 20-30,000 diseases, and that doesn't even count on the staging, the subtype, etc. Right? And another challenge really come from the modeling side. Our CS folks really not making our life easier. Every 3 months, there's a new model coming out from the GitHub, so we have to follow up. And I think a fundamental challenge is really the data format. Even though the principle it's simple, but data driven. But when data coming in different format, and that really makes the deep learning, the modeling AI complicated, right? What you're seeing here is data from genomics, imaging, and video, etc. And you saw this video from Joe already. So and text, and also the machine. So not only that, but also the data are very noisy, and that's a real life problem. And small sample size, right? A lot of time it's hard to get enough data to train our deep learning model. I'm missing data, right? So these are all the real life problem that we have to deal with when we really talk about AI. And specific to imaging, we have a different type of modalities from X-ray, ultrasound, CT, and even within each modality like MRI, right? You talk about T1, T2, dynamic contrast enhancement, you name it. So how do you really integrate all this imaging and the patient data into one super model that it's challenging for oncology application? And well, in a nutshell, deep learning is simply mapping from a variable X to Y, right? So you get, so there depends on the application. I mean, in the clinic, we have a different type of application. We can divide deep learning into 3 major categories. The first category is that the input and output are in the same domain. Think about a old photo, and you want to repair it, right? A cropped photo, and you want to get a high resolution photo, and that both input and output are in the same domain. And this is actually a clinical application. In radiation therapy, we calculate those, but if you use a very highly accurate dose calculation engine to simulate the photon transport inside the patient, and that's gonna take a long time. You talk about 1 hour, 2 hour. It really depends on what is the spatial resolution, what is the accuracy you want to achieve. But then on the other hand, there is some you can calculate in the low resolution, right? So using deep learning, you can map a low cost, a low resolution image or dose distribution into a highly accurate and high resolution image. So that is actually is happening now, and you can see that this is a work done by one of my visiting students. So we're talking about sub-second dose calculation in radiation oncology clinic, and this type of calculation used to take hours, without just using the brute force physical modeling. So now you can get it done within 1 hour, within 1 second. Okay, so it's a huge impact, and the same principle you can actually apply that to other type of data, gene imputation, for instance, where you have a noisy and then even missing gene expression, and then you want to actually use deep learning or machine learning to really map to fill the missing data. Okay, the second type of application, the input and output are in the same, but they're in a different domain, but they are representing the same patient. Give you example, if you take a CT scan, the raw data, right, the sensory data and the imaging are different representation of the same patient. And actually there is a analytical relationship between the two. But here we want to do a data-driven transformation from one domain to the other. So that has a lot of utility in the clinic. And the third category is input and output. They are in totally different data domain. You're running a clinical trial, right? You have the X is the drug you gave, and then the Y will be the clinical outcome. So you want to really relate this two by using a deep learning model. So those are 3 different category of applications. So let me just walk you through the radiation oncology workflow. So this is when our patient come in, normally we do a so-called imaging. So this the purpose of this imaging is really to build a 3D patient model. Which means that the imaging is done with the patient in the position that he or she will be treated in a radiation therapy setting. And so on the imaging side, deep learning has a lot of application. It's really advancing this imaging technique, from what we're doing today, just purely analytical or model-based reconstruction to actually a data-driven image reconstruction. And for those who went to Chicago for the RSNA meeting this year, you saw there are a lot of dynamics, a lot of vendors actually already come up with a AI solution for image reconstruction. So after patient is scanned, and we do a so-called modeling, right, where you actually segment the tumor, segment the organ at risk, and then build a 3D model for radiation therapy planning. And so, I mean, not long ago, actually, this procedure is totally manual process. So the physician or technician segment the tumor, segment everything just slice by slice on a CT or MRI scan. So which you can imagine how long that takes, okay? And then treatment planning is another labor-intensive process. The goal here is really to run a simulation, okay? To use computer to simulate the actual radiation therapy treatment based on the model that you build from the imaging and segmentation, and then do the optimization so that you can maximize the dose to the tumor, and then minimize the dose to the organ at risk, right? In this particular patient, you can see that the patient's C-spine has a tumor, is a tumor volume. You want to have a high dose to the red, and then spare the spinal cord. And the next step is really an image delivery, image guided delivery. So you push this treatment plan to the machine, and then you deliver under the image guidance. So that's, and the last one, but not the least important one, it's really the therapeutic assessment, right? After treatment, or even actually before the patient treatment, you want to have a reasonable assessment. What will be the toxicity, the side effect, and also the survival, okay? So just give you a few quick examples. So this is actually imaging data acquisition on the left, and then this is image reconstructed from the measurement. And you know, I mentioned this process, what's a analytical model or just a iterative model to do the image reconstruction. So with data-driven, you can actually bypass the old technique, and then using deep learning, actually plus some prior knowledge from prior data, you can get the image. So this is really what you can do now. In the old days, you have to take a lot of measurement from 0 to 360 degree. You have to take about 1,000 projection, okay, 1,000 X-ray projection in order to get a decent image. So with deep learning, with prior knowledge, and this landscape is changing, you can actually, you know, get a 3D volumetric image with very little measurement data, okay? So this is actually image acquired using one single projection instead of 1,000 projection, okay? So I'm not going to go to the very detail, but there are a lot of work still being done in my lab, try to improve this procedure robustness and interpretability, etc. And you know, this is just another example. You can reconstruct a 4D CT based on a fluoroscopic projection image, okay? And the same applies to actually MRI. You can take a very minimum amount of measurement and then get an MRI scan. So the implication there is really you can get a volumetric MRI image in nearly real time, okay? And then for our radiation therapy, you know, we have many machines that actually integrate MRI and X-ray, the linear accelerator. So here, you know, we can provide real-time MRI image, and then that feedback to the linear accelerator so that we can actually better treat the patient, okay? Segmentation, again, you know, this is a data-driven process. I think there are a lot of work still needed to really move that to the next level. What you're seeing here is, you know, we can segment not only its normal organ, but also actually the tumor volume. So that is an active research area. You know, how do you really mimic the physician to segment the tumor volume? So so this actually already in our radiation oncology clinic, you know, we were able to use deep learning model to automatically segment all the structures and for radiation therapy treatment planning. And we have over 10 patients already. So the initial feedback is actually, you know, with a very minimum very minimum change, we can actually use that for clinical treatment. Just want to deployment of AI to the clinic is totally, it's very important but very challenging task. So so in this review article we actually talk about all the challenges. So this was done with Joseph Wu and James Zhou, and lead by one of the very talented medical student, Angela John. So treatment planning, I don't think I have time to talk about it, but nutshell, that's also a data-driven process. So we can use deep learning to automate the treatment planning process. Again, we are not only publishing, but we also actually pushing that into our radiation oncology clinic. Image guidance. So this is where we are today. In order to treat tumor, we take a real-time X-ray and then identify the tumor by some implanted gold fiducial. So with deep learning, you can actually you can localize the tumor very robustly without surgically implant any markers. Okay. Outcome prediction. I think Rijang gonna talk about it. I just want to briefly mention that this is actually a very active research area. You can, based on the patient information imaging and lab test and genomics data, you can actually build a model to predict who will be the responder and even the survival of the patient, recurrence, etc. So these are the different type of data you can input to the model. So that include the gene mutation data and then gene expression data, etc. I think around out of time, but this is a data-driven technique that analyze the gene expression data to get the spatial mapping of the cells. Okay. So I think I'm gonna skip this neural representation and then come to the last but not least question, that is really the interpretability. So in general, I can summarize. There are 3 different type of approach for interpretability. One is so-called relationship. You relate your output with your input and then highlight the region that in the input that's responsible for a certain decision. And perturbation, you can mask some region of your input and then see what is the influence, right? And the third one is visualization. Give you an example. You want to visualize the feature space data inside your deep neural network. And this is really an example, 14 classes, we are developing some deep learning tools to visualize the feature space data. You can see that with a new feature space visualization tool, you can see the classes at the different layers, but with a conventional tool, you don't, okay? So this is my summary, and I'm gonna really finish up by acknowledge all the collaborators and students and postdocs. Thank you very much. I'll stop sharing. Let's see. I don't think we have any burning question. Let me see the Slido. Yeah, I don't see any question, but I think we'll go on. We may have some time for further question at the end of the session. Let's see. The next speaker is Professor Rijang Li. So he is from Radiation Oncology Department. Has done a lot of fabulous work on outcome prediction using AI. So Rijang, are you? Okay, good.
You see my screen?
I'll start counting time.
Can you see my screen?
Yes, please go ahead.
Yeah, thank you, Lei, for that kind introduction. It's a great pleasure to be here and talk to you about in specifically in the context of personalized cancer treatment and how AI can be used to achieve that goal. So just a very broad view of how AI can be used in oncology. There are two very broad approaches. And the first one is this so-called videomics approach that relies on expert domain knowledge. And here we can design this morphology, this texture, intensity features, and then use classic machine learning approach to predict the outcome. The second approach, which really has exploded in the past decade, which is this deep learning approach. This does not require expert knowledge. Instead, it just takes in the image and through layers of convolutional networks, then it produces output. The end goal for these two approaches, they are very different approaches, but the end goal is the same. They can be used for detection, diagnosis of cancer, prediction of response, and prognosis. So how to really translate all these tools into clinical practice, any of these imaging-based biomarker has to pass through three different phases of validation. First one is technical validity, which we have to make sure the imaging model is robust to different imaging protocols, which we know that can be different across different institutions. The second phase is clinical validity, where we have to make sure the model is generalizable across diverse patient populations. And the third phase is clinical utility, where you have to show the imaging model can actually improve survival in a randomized clinical trial. So that's a long road, but I will mainly focus on the first two, technical and clinical validity. So there's really been a lot of work on radiomics in the past decade. The issue, the major roadblock is really this lack of reproducibility. We can see many papers have been published, but really it's very little clinical translation. So the fundamental question is, can we identify features, robust features that we can apply across different heterogeneous diseases and across different modalities? So in this work, we really push this frontier by looking at three different orthogonal axes of radiology features, where we showed it can be applicable across different tumor types and imaging modalities. Just a little technical detail. So here in this study, we hypothesized two broad categories of features. One is tumor morphology, the shape of the tumor. In traditional radiomics analysis, usually this is just the shape analysis, just a few handcrafted features. Here we look at a systematic approach to describe the tumor morphology by a spherical harmonic decomposition, which allows us to reconstruct the tumor morphology in a complete manner. The second broad feature is the spatial heterogeneity. We know the tumor can invade surrounding tissues, and that's really a hallmark of cancer. So during that invasion process, there can be differences across the tumor core, the invasive margin, and the surrounding tissue. So by looking at the heterogeneity across these different regions, we define this spatial heterogeneity features. So to really identify these imaging subtypes, we look at 16 different 12 different cohorts, overall 1,600 patients with lung, breast, and brain cancer. They used unsupervised learning to identify these 4 different groups or subtypes of tumors. So they are not separated by the cancer type. We have 3 different cancer types, but by the radiographic features, specifically the tumor size, the tumor shape, complexity, and spatial variation. So what do they look like radiographically? The first 2 subtypes are small to intermediate tumors, and there are 2 groups with large tumors. The third type is has a very smooth margin, smooth shape, but ill-defined margin. And the last group, subtype 4, has very complex shape. So what do they behave? What do these tumors behave clinically? So this is for lung cancer. We showed the 4 different subtypes have very different outcomes. That seems to be pan out in the other 2 cancer types. The most consistent finding is in this subtype 4, which has really the worst outcome regardless of tumor types. And this is true even when we adjust for these clinical risk factors, including stage and tumor volume. So does that mean this subtype, these patients are doomed? Fortunately, we have this new generation of cancer therapies, immunotherapy, and it's been really used across a variety of tumor types. So in lung cancer, we showed that the different from patients who got a traditional treatment, the patients in this subgroup 4 actually had better survival when they are treated with immunotherapy. And when we look at the tumor, the immune infiltration, we found this group of tumors have a high infiltration of immune active cells, including T cells and natural killer cells. And that's consistent with the biology of these tumors. So that's radiomics with that requires expert knowledge. With deep learning, really that field in medicine actually took off with this paper that was published just 5 years ago. But since then, there's been an explosion of studies being done in this area. This is for skin cancer detection with the deep learning approach. The question is a little different when we are thinking to use AI to guide treatment decisions, because the stakes are much higher here. And in machine learning, we know this fundamental trade-off between accuracy and interpretability. I think when we want to use AI to guide treatment, the physicians want to know ideally how not only it's accurate, but also they want to know why this model works. So there are several strategies to do that. One is use this knowledge-based approach with feature engineering, where we design the features based on our domain knowledge. That's the radiomics approach I just talked about. There are 2 other approaches. That first one is to guide the deep learning model with the fundamental biology, which can tell us why this model works. The second strategy is to really leverage the human expertise and with in a collaborative setting. So for the biology informed deep learning, we know in this at least in cancer, there's really extensive research has shown the tumor microenvironment really is a critical driver of tumor progression, and also it's a key determinant of treatment response. So with that knowledge, we then developed a deep learning model that can predict the underlying tumor microenvironment from a radiographic image. So specifically here we look at two established markers in the tumor stroma, which are known to promote metastasis and resistance to treatment. So we have 4 different stroma classes, and the model is trained to classify the tumor stroma class based on the pre-treatment CT image. And as we know, this stroma class really is a very important prognostic factor. So we showed this imaging-based model really can predict patient survival in a large multi-institutional data set. This spans 3 different institutions with over 2,000 patients. So not only the model is model prognostic, it also predicts patient response after chemotherapy. So we showed only patients who had low stroma can benefit from chemotherapy. And so we did a little further extension. We'll look at not only the stroma, but also the immune microenvironment. Here we divided patients into 4 groups, depending on the immune and stroma status. Again, this is predicted tumor microenvironment from imaging. We show they have very different response rates and different survival patterns after immunotherapy. And for immunotherapy, we have a clinically approved biomarker, which is PD-L1 expression. And we showed this TME-based model can actually further improve the prediction of immunotherapy response. So the second strategy I'll briefly touch upon is this human-AI collaboration framework, where we are used to seeing this situation where the physicians are competing against AI. So I think a more effective strategy is really to leverage this AI model and to see whether that can improve clinicians' performance. So in this context, we're looking at the prediction of peritoneal recurrence, which is the most frequent recurrence in gastric cancer from CT image. So the model is, the deep learning model is pretty good with the EUC of 85%. Then we asked 3 different clinicians to estimate each patient's risk of recurrence. They did a pretty also pretty good job, but when we provide the output of this deep learning model to each of the clinicians, they actually showed a much improved prediction in much improved sensitivity in predicting recurrence. So this falls under the general concept of human in charge, machine in the loop. I think that could be one potential strategy to apply AI in this high-stake setting. And the last topic I'll touch upon is this: how do we use deep learning for longitudinal imaging? So in imaging, it's we often use this for surveillance, for follow-up, and for response evaluation. So so this is a very typical thing we see in medicine. The most AI deep learning approach is developed for looking at one single image at one time point. So when we have these multiple images at multiple time points, in this case, we're looking at rectal cancer patients who had, when typically they get a pre-treatment scan, MRI scan, before a neoadjuvant chemotherapy, and then after they get another scan before they go on to receive surgery. So the question here is, can we actually predict the pathologic response before surgery using the pre and post treatment MRI scans? So the particular architecture we look at is this multitask deep learning model, where it not only predicts the response, but also it tries to segment the tumors from the two scans. The reason for doing this is, one, the tumor volume change is really, it's actually the basis of tumor response assessment. So that's the critical information. We want to leverage that. So we applied that model to and tested it from two different centers, and we showed the model is it's accurate in predicting pathologic response, and also it outperforms these more traditional models that doesn't really doesn't perform segmentation. So and we have follow-on clinical validation in additional patients. I'm looking forward to the that paper coming out soon. As a final slide to summarize, so hopefully showing the potential of using AI and to really extract useful information from imaging and to personalize cancer treatment. To move forward, really the next critical step is really to perform this prospective validation in clinical trials. From a research perspective, I think the next phase really to we often look at one modality, either radiology, pathology, genomics. We work in silo only, but I think to really maximize the precision, we need to integrate these all sorts of multimodal data sets and develop next generation multimodal machine learning tools to integrate this data and for predicting patient outcomes. And I'll stop here. Happy to take questions.
Right. It's a great talk. Thank you, Rijang. Let's see, any burning question? You can type in from the Slido, but if not, you can still asking questions at the end of this session. So I think in the interest of time, we will move on to the last but not least speaker, Professor Mohsen Beatty, who is a professor from operational research and has done a lot of exciting work on using AI for prostate cancer data analysis and prediction. So Mohsen, can you share your screen? Yeah, do type your questions through the Slido. I see there's a one or two for previous speakers. We will answer at the end of the session. But if you have more questions, please type them in. Okay, so Mohsen, the Zoom is yours.
Thank you, Leigh, for a very kind introduction. So this is joint work with, I'm going to talk about two papers from kind of summarizing two recent, mostly work in progress. One of them is completed, the other one is work in progress. And let's see. Oh, right. So this is in collaboration with Dr. Banowski. We are co-leading a series of projects on applications of machine learning for treatment decision-making for prostate cancer at the moment. And in fact, the full list of collaborators are here. We have also Dr. Xing also working with us. And the main student, like first author for both projects is Jacqueline Vallon. She's a student in Management Science and Engineering department. Okay, so let me start with one motivating slide. In fact, I've been working for last, I would say, 13 years in applications of machine learning in various areas of healthcare, building models. I've built models that are running in hospitals for predicting the admissions, predicting emergency wait time, or various other applications. And the last few years in the prostate cancer area. One motivating slide, in fact, is this slide, which is something that I have seen myself as well going on. So, going forward a decade ago, if you all remember, like this IBM Watson beating the best human in this game of Jeopardy, and you've seen many examples of this, like Google's AlphaGo, etc. But I want to look at Watson because IBM actually built $1 billion business around it. And one area that they tried to attack was oncology. But if you fast forward about 10 years later, they realized it's not that easy. It was difficult. It turned to a money-losing business that eventually IBM sold all the assets. So I actually encourage reading these articles or several Wall Street Journal articles about these. There are some interesting themes that are highlighted. There's a lot of reasons why it didn't work. It's not you cannot point to like one or two reasons. But two reasons that they highlight have to do with one, oftentimes AI, the data that AI has access to doesn't actually have the relevant information for a complex disease like cancer. So electronic medical records doesn't fully capture that information. I mean, we just heard great talks about actually like latest advances have access toward the imaging and textual information. And this is actually an area that, I think the IBM system wasn't doing well at the time. And the other aspect is, the article actually highlights there's a lot of machine learning models. For every pretty much prediction task you look into, there are many machine learning methods that are all very accurate when you look at like the accuracy of the prediction. But oftentimes they act very strangely. They make predictions that are very strange. And in a way, they don't earn the trust of the practitioners. So just summarizing, this is like one very kind of a focused view of the problem. So look at like these risk prediction models that are used for the decision making. And this is typically the pipeline. So you have a pipeline that models are like trained, there's a machine learning engine, and then it produces results that are given to clinicians at the point of care. And you would argue that, at least a lot of times, the defense of a system like this is, even if the predictions don't make sense, you have a clinician that makes the final decision. So they can override what we call models that don't make sense. And I will be actually more specific what I mean by that. But one thing that I want to argue today is, we actually need to bring clinicians' expertise in this step of the process further. Like we need to integrate, and there is a still gap there. And in fact, the gap between clinical practice and the machine learning model development is increasing, surprisingly. And the main reason is automation. Because of automation, we end up relying less and less, and if for obvious reasons, we need to do these things at scale. There are also like things around experimentation, but today I will not discuss them. That's also part of our collaboration. So, by the way, feel free, please let me know if I run out of time. Okay, so let me talk about these two areas, and actually want to like put one like a supervised learning 101 slide, because the two areas like are really starting from here. So step one of a supervised learning process is, you take a patient and you translate patient data, electronic medical record data, et cetera, into what we call a feature vector. And there's an outcome that you're trying to predict. Sometimes, of course, there's a lot more outcomes like in multitask learning, but for now, let's just look at this simplified setting. And then the next step, once you put the data into this framework, you just apply a machine learning method to, or so-called train the model to predict Y given X. So for the first, like, let's say 7-8 minutes, I'm just gonna focus on step one. And specifically look at the feature generation part. So we took 147 prostate cancer patients who were treated with surgery or radiation at Stanford. And we created a very extensive set of features for them. The features, of course, consisted of what we call structured data. So things like lab results, comorbidity scores, demographic information. But then there's also medical notes and specifically biopsy reports in our case that are very rich on structured data. So summarizing structured features and unstructured features. In anything I say today technically should be applicable to images. In this exercise, we didn't use images. It was the actual reports, but as unstructured data. So the question is, how would you use this information in building features, right? So what's very common because of automation that I described today is using these automated natural language processing methods. So specifically, we're going to compare two approaches to apply to these nodes to create features out of them. One is automated NLP. These are like modern advances in last 5 years, like these transformer deep learning methods that are very effective in many domains. And then there is the second approach, which I call patient level clinician. And this requires per patient chart review by clinicians. The second bullet is not at all realistic. Like it's very difficult to do this in practice because it's very expensive. But just as a thought experiment, we decided to do it. That's why we don't have a lot of patients. Like this is a very expensive process to do. It took us a year to do it, but we did it for 150 patients. And for every single patient, like we had clinicians in consultation with pathologists come up with features extracted from that notes. And we decided to compare these two. And of course, in a way, we are comparing three models. A model that just uses this structured data as features. A model that uses the structured data plus the automated NLP applied to notes. And then the third model is baseline plus the patient level. So we are comparing these two, but adding baseline to both of them as well. So in short, these are three sets of models. And I'm kind of listing the features that are extracted here and the title of the features in reality and the number of them. And one thing I want to mention is this set is actually a very large set. Like these automated NLP methods create hundreds of features, but we apply some dimensional reduction method on them to extract a smaller set of features with the same level of accuracy. Okay, so this is just a list of features, but let me just summarize one thing. Like, why is this patient level clinician feature generation different than, typically you have heard this is the steps 1 and 2 of this process is very standard approach. Like you use domain knowledge to create some features, and then you kind of define a mathematical formula or logical rules that creates, allows you to create that feature at scale, but applying it to a lot of patients. But sometimes you cannot do that because those basic data points are not applicable, like are not available in some patients, and you need to go back and revise the formula. And this is why we needed this per patient. So for every single patient, like this really 3B is like 1, 2, and 3A is what's a standard, but 1, 2, and 3A or B makes this unusual. And this B is really what makes it technically not, it's just an abstract, let's just call it idea that we tested it. So here's the summary of the results. The three models, the baseline that uses structured features, the baseline plus automated NLP, and then the baseline plus this patient level clinician feature generation. And this is the prediction accuracy in terms of AUC. The main takeaway I want to highlight is like there is actually a lot of signal information that a clinician, their experiential learning can bring to the table to extract data, signal from their notes. And we have, done a ton of sensitivity analysis. The results are very consistent. You want to change the machine learning method that does the final predictions from the features. You want to change the AUC to precision recall or other metrics. You want to change the imputation method for missing data or number of faults. Like the green one is always the superior one. So that's the summary of like this first part. And I just want to summarize like in one takeaway. There is a need for efficient integration of patient-level clinician reasoning into feature generation. Maybe we need a platform, some way that we can leverage clinician expertise at scale to generate features. This is a completely, as I mentioned many times, abstract. It's difficult, expensive to implement, but there is value in it. So that was really the goal of this exercise. Now I'm going to move to the second part, which is going back to the supervised learning pipeline. We talked about features, but now let's talk about this part, right? So this is actually the work in progress. The first one, we have a draft available on medRxiv. The second one is a work in progress. We have a conference paper in Astro, but I will present some results that are also recent. So let me mention, what do I mean by when at the beginning I said sometimes these models don't make sense. So here's an example. You have two patients, A and B, that are clinically very similar, and cancer is more advanced in A than in B. So that's the only difference between A and B. But then, so technically, if I have a survival prediction model, I should predict higher survival for B than for A. That's the right thing to do. But you'll see the ML model actually mistakenly predicts higher survival for A than for B. And what's the reason for that? So one reason, and this is becoming more and more common as models becoming more modern, and one common theme of modern models is like over-parameterization, or we call under-specification. It's a recently well-documented issue. What happens is when you have a very over-parameterized model, then this concept of bias and variance trade-off that happens can cause problems, because the ML tries to bias its predictions to avoid variance. And the hypothesis we had when we started was like these artificial biases may actually contradict clinical experience. So that was our hypothesis. Now we decided to test it. We took National Cancer Database, a much larger scale data set here. Similar set of features, of course, less extensive than the first part of the talk. And we tried to predict 10-year survival. And so these are the features. The features are less important. What I want to show you is what we find in terms of like we, for example, use a lasso model. The results are similar if you use like boosted machines or various other models. So we get something like this. So here is an AUC, a test set AUC on this data set. But look at specifically, for example, this variable. The y-axis is the probability of survival. The x-axis is the way the variable age is contributing to survival. Surprisingly, as the patient age is very high, suddenly survival becomes higher. That's surprising. It shouldn't be the case. Or look at PSA. As PSA increases, technically survival should actually decrease, like these high values of PSA. But we see like this kind of non-monotone behavior. And then for Gleason score as well, there's this kind of a idiosyncratic behavior of the way the model is actually performing. We typically, like when we say under-specified models, it's because the pipeline usually tries to optimize for a metric like AUC or PR, precision recall, or some other accuracy metric. But usually we ignore these issues, and that actually can be a problem in the modern ML methodology. So now let's just look at a histogram of the data. So immediately you will see that, like for example, in this regime, there's not a lot of data. Or the same way here, like as soon as you get out of this range, there's not a lot of data, like not a lot of data here, not a lot of data here. And with PSA as well, like there's not a lot of data where you see this kind of very idiosyncratic pattern. So this kind of bias variance, this is more evidence that it seems to be the problems are even more pronounced when we have less data in those regimes. So and in fact, when you look at a model like Lasso, how does it do the bias variance trade-off? This is like this kind of a L1 penalty. I don't want to get into the math really, but I just want to highlight there's a mathematically motivated bias that is appearing here. And why is that? Why should that be there? I mean, there's an experiential learning knowledge of the physicians that could potentially be better. So now we decided, what if we use clinical knowledge as bias? So we created a survey. We asked several physicians to look at, give responses to the survey, and then we used their knowledge to tell us which variables should they contribute to their survival. And we added those constraints to when we are training the Lasso model as constraints into the optimization problem. And then we compared the AUC of this kind of constrained model or enhanced model with this original model. And in fact, just to show you an example of the survey, for example, the survey asked them, let's look at Charlson Comorbidity Index. From your opinion, for the survey respondent, do you think it should increase or decrease or have no effect or increase or decrease depending on other factors? Not sure. Like one of these, they should give one of these 5 responses to the probability of survival. And then we looked at when there was consistent response across all the respondents in terms of they all said the variable should increase or decrease. So for those ones, and in fact, this is the list that they came up with, which is then we use these variables to constrain the training of the machine learning. And this is what we get, the last row. So if you notice, the relationships become monotone. We didn't tell it specifically it should be this shape. All we told the Lasso model is that you should predict a lower risk as you go to the right. And the same with this and the same with that. But one thing you want to notice, it looks like I restricted the Lasso, but actually I didn't lose in terms of test set accuracy. So in short, the model, if you just look for accuracy, may be very idiosyncratic. You need to specify more constraints and you don't lose on the accuracy, but you actually come up with a model that can earn trust of the practitioners. Now, just one last 2 slides. So, I'm not trying to detect causal patterns. That's a separate story, right? So, and in fact, those of you who look at causal relationship detection, you may say, maybe the reason this idiosyncratic behavior exists is because of confounding factors. But we did a simulation to show that's not the case. Even in simulated setting, where there is no confounding factors, we literally created a linear function, right? This is a linear function of this one variable. And I have several other just noisy variables. And then I look at, the orange line is the true line that the model should learn. But using different models, you can see the predicted one is not following the same pattern in some cases, especially these tree-based models are more problematic. So summarizing, the second takeaway from today is nearly all modern ML methods create bias predictions and hence need to be evaluated based on experiential learning. So that's the main takeaway of the second part. And with that, and the summary of these are, 2 of these are the papers that I mentioned, and the other one is work in progress. So I'm gonna stop at this point the share.
Right. Great. Well, thank you for staying on time. We have 5 minutes for Q&A. So the floor is open for basically all the panelists. And I see there is one question for you, Mohsen. How
So
did
the question
you
was about
handle missing values?
Yes, thank you.
Question.
Yeah, so we have just, I may have, this question may have come up before I showed this slide. So we use different missing value imputation methods as robustness checks like mice, SVD imputation, mean imputation. But sometimes we actually use, like in the feature generation phase, the clinicians, one job of the clinicians when they're generating those features indeed is imputation, because they see the data is missing, but they can still interpret from the rest of the information one value for the feature. So clinicians are doing both imputation and feature generation.
Okay, that's great. Yeah. So another question. Let's just answer the question first before we go to freestyle chatting. Well, this is really for me. Can you go over the treatment planning research that you quickly glossed over? Well, yeah. Well, thank you for asking that question. Yeah, I didn't really have enough time to talk about the detail on treatment planning. But in a nutshell, treatment planning is a process that you optimize the machine parameters for a given set of clinical goals, right? So this clinical goal can be outcome-based. You say, hey, I want patients survive 10 years, 15 years with maybe a minimum 5% complication. Let's say if you're treating lung tumor, you can specify, hey, I want the complication rate for pneumonitis to be less than 5%, etc. But those type of goals are very hard to optimize, and most realistic goal in the clinic is really, I want, it's we call the isodose based, right? I want the dose to the tumor covered by, let's say, 95% of the tumor covered by 100% isodose line. But in the meantime, I want the lung, or let's say lung, the dose volume histogram to satisfy certain physical constraint. Let's say, so 20% of lung get a dose less than 25 gray, or those type of constraint are very, it's basically a standard of practice. In order to do that today, it's being done using so-called manual optimization, because you have to really tweak a lot of parameters, like a weighting, for instance. You have a lung, you have a tumor, you have maybe if near the heart, right? So you want to give certain weight to the heart so that the cardiac toxicity will not be high. If it's close to the esophagus. So there's just a lot of clinical factors need to be considered in this process. So the way it works is really just manually tweaking all the parameters and then do it. So with the data-driven, the way it actually works is really we predict based on the history, based on data, we can actually come up with a deep learning model or machine learning model, if you will, and then predict what is achievable in the based on historical data, and then you actually start from there. You do the optimization. So that will be a much easier process clinically. I think I got a warning that there is a 1 minute left. Are there? Let me see the. Okay, I don't see a new question coming in. But with the timing, I think we have a 1 minute, 1 minute left. Okay, so it's 1:30 already. So I want to take this opportunity to thank all the panelists, Dr. Liao, Dr. Li, Dr. Beati. Thank you for your contributions, great panel, and also want to thank all the audience for your participation and for your feedback. Enjoy the rest of your meeting. If you have questions, feel free to email to the panelists, and then we'll get it done. All right. Thank you very much. Bye-bye.